Good evening and welcome to this PERT Consortium webinar, Which Therapy for Which Patient? A Pro-Con Debate. My name is Jeffrey Barnes. I'm from the University of Michigan, and I'm honored to serve as our moderator this evening. This webinar is sponsored by the PERT Consortium, and we are grateful for their support to put on this important discussion. The PERT Consortium has several very important industry partners, and we'd like to thank them for their support of all that the PERT Consortium does, including these educational webinars. You can see here our bronze, silver, gold, and platinum supporters, all of whom contribute greatly to this educational effort. Before we jump into the webinar, I want to remind everyone of the upcoming 9th annual Pulmonary Embolism Symposium that's going to be held in Austin, Texas, September 21st to 23rd. It's going to be a great meeting. We really encourage everyone to attend, and you can scan right here on this QR code if you have not yet registered. It is a great place to be. There's going to be a ton of great education happening and a great way to network with your colleagues and experts in the field. And for anyone who is a physician in training or works with physicians in training, we want to encourage you to think about attending our Physician in Training boot camp that will happen just before that Pulmonary Embolism Symposium. This will happen on Wednesday, September 20th, and it is free to all residents, fellows, and medical students. So scan here to get more information, and please pass this on to any physicians in training you know who are interested in the care of patients with venous thromboembolism, especially those who are interested in the care of patients with pulmonary embolism. We also want to make sure everyone knows that the Pulmonary Embolism Centers of Excellence program is coming soon. You can scan right here to learn more and declare your interest. There's going to be an opportunity to be declared a center of excellence at both the comprehensive care center level and at the regional care center level. This is a really exciting opportunity that the PERT Consortium is leading, and I encourage you to scan here and learn more to see how your center can become a PE Center of Excellence. Tonight, I'm honored to serve as our moderator, and I'm joined by 4 amazing faculty, and I want to introduce each of them briefly. Our first is Dr. Brandon Hooks. Brandon is a pulmonary and critical care physician in Grand Rapids, Michigan. Brandon is going to be presenting our case this evening. We also have Dr. Vlad Lakhter. Vlad is an interventional cardiologist and vascular medicine specialist. He's in Philadelphia, and he'll be presenting as a part of our PERT team this evening. We're thrilled to be joined by Dr. Sofia Nadanov. She is also a pulmonary and critical care faculty member in St. Louis, Missouri, and a longtime member of the PERT Consortium. And of course, everyone knows Dr. Allison Witkin. She is the Associate Director of Pulmonary Hypertension and Thromboendarterectomy, a pulmonary critical care physician in Boston, Massachusetts. Now, I want to remind you all to become a part of this webinar as well. So thank you for joining us. Become part of our conversation. As our webinar is going on, you can click on that Q&A button down there at the bottom of your Zoom screen, and you can submit questions for us to discuss at the end as a panel. You can even submit some of your comments, and we'll try and build those into a little bit of our discussion as we go through. So please become a part of this webinar. And as always, these webinars are recorded and will be available online. And so you can go to this link here, pertconsortium.org, and then PERT-webinars, and that's where you'll see a collection of all the prior webinars. This one will be joining in just a few days' time. So we look forward to having that available for anyone who couldn't be with us live tonight. So to get us started, I'd like to invite Brandon to present a case presentation that's going to frame our simulated PERT call here. So Brandon, let's turn things over to you.
Jeff, I want to say thank you so much for that great introduction, and thank you to the PERT Consortium for this opportunity to highlight a very important case that we often come across clinically on a day-to-day basis. So I want to present a patient, 53-year-old patient, female, who presents to the emergency department with progressive symptoms of shortness of breath, exercise intolerance, and leg cramping. Often had thought this was maybe due to lack of physical fitness or just some generalized malaise. There was no history of recent travel, immobility, or known hereditary thrombophilias. She reports that she's not on any hormone replacement and denies any prior history of venous thromboembolic events. Past medical history has hypertension, obstructive sleep apnea, which she is compliant with her CPAP therapy, hyperlipidemia, and obesity. Her home medications are listed here. Upon presentation to the emergency department, we note that the blood pressure was 106/55. She's tachycardic, also tachypnic, a little bit anxious appearing, with slight tachypnea. Oxygen saturation was 91% of room air. After she was given 2 liters of supplemental oxygen, her oxygen saturation did improve. Her body mass index was 39. And what we see as part of the initial blood chemistry, slightly anemic with a elevated high sensitivity troponin. I don't know if others joining the call are using the high sensitivity troponin in their institution, slightly elevated with an elevated D-dimer blood test. As far as the physical exam, again, what we notice is a obese female who is slightly anxious appearing, neurologically intact, with clear breath sounds, slight tachycardia with regular rhythm, and also findings of calf asymmetry with some edema noted in her right lower extremity. The initial chest X-ray is shown on the screen to the left, as well as an EKG demonstrating sinus tachycardia. The decision was made, given her presentation, clinical history, and high suspicion of pulmonary embolism based on her laboratory studies, to perform a CT angio-PE protocol. And these are axial images that I've taken some snap pictures of. As you can see, within, starting at the left upper image, thrombus and filling defects within the left pulmonary artery, as well as in the right pulmonary artery. Slight dilation in my review of her pulmonary artery size compared to her aorta. And moving downward, again, noted thrombus and filling defects within her main pulmonary arteries, as well as segmental pulmonary arterial branches. Some that appear more central and some appear more adhered to the side of the pulmonary arteries. The thing that I want us to take note of is on the bottom right, I've identified the pictures of her heart that do suggest that there is right ventricular enlargement, right atrial enlargement, as well as flattening of the intraventricular septum. You would also see, if I moved progressively inferior to that, some reflux of contrast, which may suggest right ventricular strain. Given her obesity, I will disclose it was challenging to get good windows for her transthoracic echocardiogram, but these are the images that we were able to obtain on admission. This is an apical 4 chamber, and I'm going to play the parasternal short axis. And what you could see is some shifting of the septum. And if you look over here, you could also see some septal shifting of the intraventricular septum.
The real question that we're going to have now is, as we bring this PERT team together, how should we think about treating this patient? Is this somebody in whom anticoagulation is the best approach? Should we think maybe about a catheter-directed thrombolytic approach? Or we think about some sort of a catheter-based thrombectomy, maybe a suction thrombectomy approach? And so to kick us off, I'd like to invite Vlad Lakhter to present the argument for why anticoagulation may be the best therapy for this patient.
First of all, thank you very much. I wanted to thank you guys and the PERT Consortium for inviting me to speak here tonight. It's a favorite topic of mine. And as you would have guessed, since I'm a vascular interventionalist, I will be presenting my argument for why this patient should be treated with anticoagulation therapy alone. And so I'm going to start this off with this very interesting article that I pulled up. It was published in 1916 Lancet. And as far as I could tell, this was the first and probably the only randomized trial that randomized patients to anticoagulation versus no anticoagulation. And all of these patients had pulmonary embolism. And what we learned from this study is that anticoagulation is in fact very effective in treating pulmonary embolism. And in the study, initially they randomized 39 patients to receive anticoagulation. 16 of them were in the heparin group, 19 received placebo. And what was found was that the mortality in the group that was treated with placebo was 26%. And there were 0 deaths in the group that received heparin. And if you combine the endpoint of mortality and non-fatal recurrence of pulmonary embolism, there was actually an incidence of more than 50% in the placebo arm. And again, there was neither recurrence of P nor mortality in the group that received heparin. So heparin was known to be effective already for over 60 years. And it was interesting that after the initial 39 patients, the authors thought that it would be unethical to keep randomizing, so they included 38 more patients with pulmonary embolism, all of which were treated with heparin. And in subsequent group, again, the mortality was 0% and only a 1.2% rate of mortality plus non-fatal P recurrence. So very effective. We also know from the PYTHO trial that anticoagulation is effective, and it's as will be presented by some of the other speakers, as you'll see, where it was a trial of patients with intermediate risk PE who either received tenecteplase or anticoagulation alone. And in the anticoagulation alone arm, the death from any cause, which was the primary endpoint, which was one of the components of the primary endpoint, the mortality at 7 days was 1.8% in the anticoagulation group, and the recurrence of PE in this group was only 1%. So again, anticoagulation seems to be very effective with that as well. Now, the risk versus benefit of doing something more aggressive than anticoagulation was also explored in this trial, and the endpoint of all-cause mortality and hemodynamic decompensation within 7 days did tend to be better in the lysis group, but that did come at the expense of having significantly increased rates of major extracranial hemorrhage and intracranial bleeding. And again, reminding ourselves that there was no significant difference in the death from any cause in the patients that were treated with anticoagulation versus thrombolytics. And this is a trial, this is a meta-analysis that kind of took a look at all of the available trials, most of which were systemic thrombolysis versus anticoagulation, with the exception of the ULTIMA trial. And you could see that when you look at mortality, there is a slight potential benefit to mortality in the patients that receive systemic thrombolytics. But if you look at this forest plot, you'll see that every trial except for one, the confidence intervals cross the line of 1. So really just a borderline improvement. And what is the cost here? If we look at the number needed to treat, you would need to treat 65 patients to achieve the benefit of mortality versus the major bleeding, where the number of needed to harm was 18. So again, suggesting that anticoagulation alone was maybe the way to go, because at the cost of major bleeding that we see with thrombolytics. Now, kind of the point of this talk and this webinar is more to look at the catheter-based interventions. And so are catheter-based interventions any more effective than anticoagulation? And really the only published trial that was randomized to treat patients with catheter-based therapies versus anticoagulation therapy alone was the ULTIMA trial, which looked at catheter-directed thrombolysis versus anticoagulation therapy and evaluated the primary endpoint of the change in the RV to LV ratio from baseline to 24 hours. And what was seen was that, in fact, catheter-directed thrombolysis was more effective at reducing the RV size relative to the LV diameter at 24 hours compared to a heparin group. But when the follow-up at 90 days took place, we saw that there was a catch-up period, and the anticoagulation group was really did just as well as CDT, raising the question of whether really these early improvements in RV to LV ratio have a clinical significance to them or not, since anticoagulation therapy seems to have this catch-up effect as well. And all the subsequent studies majorly published that evaluated catheter-based interventions, the Seattle 2 trial, which looked at ultrasound-assisted thrombolysis, the FLAIR trial, which was a thrombectomy trial with Inari, the Extract PE, which was a penumbra thrombectomy trial, and the Rescue, which was the catheter-directed thrombolysis trial with the Bashir endovascular catheter, all of which looked at the RV to LV ratio really showed that there was an improvement, an acute improvement in the RV to LV ratio, but did not have any really long-term follow-up, and did not look looked at anticoagulation arm alone, which is the major limitation of these trials. And what we still don't know from the catheter-based trials are the following things. We know that the RV to LV ratio improves acutely, but what we don't know is that do catheter-based interventions reduce the risk of PE-specific death? Do they reduce the risk of recurrent PE? Do they reduce the risk of the more chronic complications like developing chronic thromboembolic pulmonary hypertension or chronic thromboembolic pulmonary disease, which is vastly more prevalent than CTEPH? And also, do these catheter interventions improve the long-term quality of life as compared to anticoagulation therapy alone? What do we know about the costs of advanced therapies if we use them? These are the trials that I already showed you, and you could see that in every trial there was some degree of bleeding complications associated with it. Although with the caveat that the risk of intracranial hemorrhage in these studies was low, especially in the trials that evaluated catheter-directed thrombolysis. But there were other complications like major bleeding, access-related complications, and especially in the FLAIR trial, there were complications related to the actual device, including perforations of the pulmonary vasculature and one death. So this is an interesting website you can access yourself, which is the FDA MOD reported adverse effects, and these are the real world reported outcomes of any complications that are reported for either ultrasound assisted catheter directed thrombolysis, FlowTriever. You can look at AngioVac. AngioVac is very rarely used at this point for PE work, but if you look at the event rates that have been reported complications for CDT and for FlowTriever, again, you can see that those numbers are not zero. And if you look at the numbers up to the current, the FlowTriever event rates have been up to 20 now. So again, there's a cost to using catheter-directed devices. And so what do the guidelines recommend for us? So the 2011 AHA guidelines, albeit have been more than 10 years since they've been updated for pulmonary embolism, recommend thrombolysis only in the event that the patient who was previously treated with anticoagulation, has intermediate risk PE, has a new hemodynamic instability, has worsening respirations, severe RV dysfunction, which they don't specifically define, or major myocardial necrosis. And they do not recommend thrombolysis otherwise with patients who have submassive PE with minor RV dysfunction or who have no worsening in their clinical status after anticoagulation. If we look at the 2016 American Chest Physician Guidelines, similarly, for most patients with acute pulmonary embolism that do not have hypotension, so intermediate risk PE, they do not recommend thrombolytic therapy. And again, just like the AHA guidelines, they do recommend escalating to systemic thrombolysis if the patient deteriorates despite initial trial of anticoagulation, and then they actually prefer systemic thrombolysis over catheter-directed thrombolysis in their guidelines. And the most recent guidelines that we can fall on are the European Society of Cardiology guidelines from 2019. Again, if you look at the intermediate risk PE, they recommend rescue thrombolytics for patients that also have hemodynamic deterioration, which is pretty much the same theme in all the three guidelines that I recommend. But what they actually recommend, again, is the systemic thrombolysis versus catheter-directed thrombolysis. As an alternative, they recommend catheter-directed thrombolysis. So I think at this time, the data that we have really do not clearly support that there is a long-term improvement in any of the endpoints beyond RV to LV ratio with catheter-based interventions compared to anticoagulation therapy alone. And I think it will be very important to get much more data, which hopefully will be coming in the next few years from the randomized trials to understand what additional benefit we're getting from these catheter-based interventions beyond anticoagulation therapy alone. Okay, thank you very much. I'm going to yield to Dr. Naidenov.
Thank you, Vlad. And don't worry, we'll allow you to speak on behalf of your interventional opportunities here in just a minute. But I'd like to invite Sophia to now present on maybe why we should think about mechanical thrombectomy or suction thrombectomy as a good option for this particular patient.
Thank you so much for having me. It's really a delight and an honor to be here and have this discussion. This is great. Brendan, thank you for bringing this case. I think we struggle and this challenge remains as to what to do with the patient, which we have risk stratified as intermediate high risk. And Vlad, you've raised some great points, and I do not disagree with you that anticoagulation remains the backbone of PE or pulmonary embolism treatment. No question about it. It's effective. It works. But I do disagree. I think we need to look at some of the other parameters in the case to perhaps consider an add-on therapy. So this is how I'd like to process it. There's some things obvious, obviously, with the troponin elevation and the right ventricle that looks in quite a bit of distress on the echocardiogram and on the CT. So indeed, this is an intermediate high risk, PE. But how about the heart rate and the blood pressure, the additional data that we have on this patient? So we do know that heart rate more than 100 or equal to 100 is a marker or a risk predictor of a bad outcome. And this is one of the study I'm quoting here. So tachycardia is one thing that concerns me in this patient, especially this number. And right at the cutoff of 100 is looked into as a reliable risk stratification marker. And if you pay attention to the blood pressure, and Brandon has been kind enough to give us a baseline, it's systolic and diastolic. Both blood pressures are predicted as a reliable markers to look into to predict patients' outcomes. So this concerns me, 106/55. This is one of the studies I've mentioned here. Systolic cutoff around 120, less than 120, and diastolic less than 65. So this concerns me. We don't have a lactic acid, but we know even venous lactate, if we had it, 3.3% is the cutoff for that to show us that that's a bad prognostic sign. And concomitant DVT, which I suspect in this patient, given her asymmetry, the swelling, the leg swelling, and symptoms in the leg, that concerns me as well as an additional risk factor. When we think about acute PE, of course, in acute situation, we are concerned about the survival. It matters, no question about it. But how about hemodynamic decompensation and long-term outcomes? Should we take that into consideration? And what do we know? What can we do in the acute phase that can perhaps impact those outcomes? So just a few thoughts that I have in mind while I'm processing this case. So let's go over to some of the risk stratification tools that we know of and apply to this patient. If you look at the BOVA score, which is validated in quite a few studies, I have labeled, if you look at the troponin, the RV dysfunction, heart rate, it classifies 42% risk for death and PE-related hemodynamic decompensation at 30 days. And her score is high. And ASPASI, as we all know, more than 0, it's a high risk score with close to 9% risk of death. And then modified FAST score is another risk stratification score. And then her with the troponin elevation and that heart rate, as I mentioned, more than 100, it puts her at a higher spectrum of illness. These scores have been validated in a variety of studies. Again, to highlight area under the curve of all of them are reliable. This is one of the studies. And then modified FAST score performed the best in this particular one. And again, 30-day mortality, as you can see, tachycardia, heart rate more than 100 was predictor of adverse outcome in these patients. This is PE patients with normotensive, who are normotensive. And Jeff, my colleague here today, they studied this for scores, the PASI, the ESC classification, and the BOVA score on the pilot registry from the PERT consortium. And then they had a modest performance in this particular study. But do we need better tools? I'd say yes, we do. But this is what we have right now. So this has to be taken into consideration, in my opinion, to perhaps think about or consider doing something additional than anticoagulation. So when you think about what to do, Vlad has highlighted a few things, but I will mention some of the studies he has mentioned, but here's my processing of this intermediate high risk patient with additional risk factors that concern me to intervene and do something add-on. When I look at the PYTHO study, yes, I agree with you. What you mentioned about that tenecteplase versus anticoagulation, more than 1,000 patients, incredibly valuable study. Yes, tenecteplase did prevent those outcomes of 7-day decompensation and combined outcome of mortality and decompensation. But it came at a cost. It came at the cost of bleeding 10 times more. So of course, not recommended to do in PE patients who are normotensive. But the important point that I take from this study is very important. Around 6% of patients deteriorated. These are intermediate high-risk patients that deteriorated. So when do we intervene and how do we monitor them is an important take-home message from this particular study. So I would not consider this because not recommended. I would not consider systemic thrombolytic therapy for intermediate high-risk patient, the one that is presented. So going forward to catheter-directed thrombolysis, I think, again, I value this Ultima trial coming 2014, that it randomized control trial on this particular intervention, and it showed benefit. It showed benefit in RVLV reversal of the ratio sooner than heparin. Heparin does the same thing, but just takes a little bit longer. But we do know that the patients decompensate in that acute phase of that 1 to 7 days. So we extrapolated that perhaps that benefit of reversing the ratio faster than what anticoagulation alone can do is of benefit to the patients. We haven't proven mortality benefit. There's no question right now in that particular aspect, but something to consider to prevent that deterioration. But you still give them TPA. Seattle 2 trial, which had the ultrasound assisted thrombolysis, 10% risk of major bleeding was there. So something to consider. I don't consider that as an option. This particular patient, given she does not individually have a high bleeding risk in my mind, but the bleeding risk remains as when we have TPA. Procedural duration, I think, sometimes we plan to give it for 8-10 hours. It stays longer. So I personally think we have a safer option. So I would not consider catheter-directed thrombolysis in this particular patient. When I look at suction thrombectomy, we have the FLAIR trial and the EXTRACT-PE trial. These are trials that suggest that the suction thrombectomy procedure can be done effectively, safely in expert hands in this particular patient without that risk of thrombolytic and potential bleed from a thrombolytic. So I would consider this in my conversation with my intervention. I don't do the procedures myself, but I would talk to them to see if they look at the scans and think it's a feasible location of the class to perhaps consider suction thrombectomy. I think it's effective, it's safe, it can be done in a timely fashion, and it's like one and done. It's out of the suite and you're done with the procedure. So that's what I'm leaning towards. And overall, I think, yes, many complications have been mentioned by my colleague. I agree. But if you look at PCI, I mean, it took 40 some years to refine it and to come up with where we stand with the drug-eluting stents. First they just did the angioplasty in the 70s, and then, yes, of course, restenosis happened. So it's learning over time. Yes, do we want complications? No, we don't. Do we want things to go well from the get-go? Absolutely. It just doesn't happen. So where are we in PE? It's been just 10 years from the first interventional trial, if you look at Ultima trial, or perhaps that that interest of, not interest, I would say, to consider trials on intervention on this intermediate high-risk PE patients with a mortality more than 10%. So I think we're a little bit early in the evolution of this, but it's getting there, and we all need to be patient. And I say there's a battleground. You have devices and technology on one end, which are evolving with a lightning speed. And then you have data, which is slowly but surely coming. Peerless trial up and running, catheter-directed thrombolysis versus mechanical thrombectomy, HI-PI-THRO, across the 2 continents, Europe and US collaborative approach of studying this ultrasound thrombolysis plus anticoagulation versus anticoagulation alone, again, will be very valuable. The PE track recently got its funding, excited, looking into the long-term implications of doing the catheter thrombolysis. All the questions that we have posed or we struggle with in these patients, we'll get some answers. The STRIKE PE and the STORM PE, which are device-related trials, but looking into the long-term functional outcomes of these patients, which is more and more interest of as clinicians, not just that initial mortality benefit or bleeding risk, but long-term functional status to allow restoration of health and functional ability of these patients, which is absolutely necessary to look into in the trials. And the APEX AV trial, again, studying effectivity and safety of the AlphaVac multipurpose mechanical aspiration device. So till we have these trials, which we all would be very eager to get the answers to, I would process this patient as a 53-year-old intermediate high risk with mortality just based on the heart rate of more than 7.6% chance, mortality more than 10%, and with the heart rate risk of decompensating more than 7.6%, I would consider to anticoagulation plus an add-on suction thrombectomy in this particular patient would be my choice to discuss as my PERT suggestion. Thank you so much.
Well, Sophia, thank you so much for reviewing all of that data and making a really great case for why suction thrombectomy should be considered. Rounding out our interventional therapies, I'm going to ask Allison to comment on why catheter-based thrombolysis or catheter-directed thrombolysis, as it's often referred to, may be the best option for this particular patient. Allison, it's all yours.
Thanks so much, Jeff, and thanks to the PERT Consortium for inviting me to participate in this webinar. So I agree with Sophia. I'm not going to go through all the risk stratifications, but this is a patient that I am worried about. I'm worried about how she's going to do over the next 24 to 48 hours. As was outlined by Vlad, there are real risks to doing systemic thrombolysis, and I think this is a great patient for catheter-directed thrombolysis. Unlike systemic thrombolysis, catheter-based thrombolysis allows for delivery of lytic infusion directly into the clot. We can use much lower doses than systemic lysis with a much lower bleeding risk that was seen. And this is a really quick procedure. I don't do this, but I've sent many patients for it, and they spend very little time in the cath lab, very little time having to lie flat while they're short of breath on an X-ray table. And unlike catheter-directed thrombectomy, right now, this is the only catheter-based treatment where we actually have patients randomized to a control arm, so we can truly compare to anticoagulation alone. I agree with everything that Vlad said about the Ultima trial, which looked, as a refresher, about randomized 59 patients with central PE and RV to LV ratios greater than 1, and they were randomized to 10 to 20 milligrams of TPA over 15 hours and compared to heparin alone. There were 3 minor bleeding complications, but no major bleeding complications, again, supporting the lower bleeding risk compared to systemic thrombolysis. And what you can see is that the RV to LV ratio, which has been shown to be a surrogate marker for the risk of mortality, was significantly improved at 24 hours compared to those treated with heparin alone. They absolutely catch up at 90 days, and I agree with Vlad on that. However, I'm not concerned right now about the 90-day outcome. I certainly want my patient to not be short of breath and to not develop CTEPH. But what I'm really worried about is this patient going to die? Is she going to have a hemodynamic, life-threatening hemodynamic decompensation in the next 24 to 48 hours? And we can get benefit even from low dose. We don't, in the Ultima PE patient, Ultima trial, patients received higher doses of lytics, but as Sophia outlined, as with PCI, they've gotten better. We're getting better with catheter-based thrombolysis. The Optilyse trial enrolled similar patients to the Ultima trial, and these are patients who had an RV to LV ratio of greater than 0.9 with proximal PE. And at 48 hours, there is a significant improvement in the RV to LV ratio compared to their baseline. While these patients weren't randomized to heparin, they were randomized to 4 different treatment regimens. And as little as 4 milligrams per lung over 2 hours saw a dramatic increase in the RV to LV ratio. Now, every intervention has risks. I'm not going to say that there's no risk from doing a catheter-based intervention, in this case, catheter-directed thrombolysis, but there's also a risk of decompensation to not doing them. And in this trial, there were 4 patients with major bleeding, including 1 with intracranial hemorrhage. However, I want to point out that of 2 of the 4 patients who had major bleeding, received additional TPA outside of the regimen. So we're not treated with the standard and intended treatment. These are both the Optilyse PE and Ultima. These are both clinical trials where everything is really well regimented. And so there was the PERFECT registry, which is published now many years ago, which has now, which showed what happens in the real world. And I just want to highlight that in this real world registry, and this is before Optilyse, even when we had less information and maybe not even quite as good as we are now, they enrolled 101 patients and found that 85% had improvement in hemodynamics and survived to hospital discharge. There was no major bleeding and no intracranial bleeding, again, highlighting the relative safety and benefit of this intervention. And one of the nice things about catheter-based thrombolysis is we actually can measure the pressures. One of the challenges is, how do you know somebody's getting better? You can look at their vital signs, but one of the concerns that we often have in these patients is that we see that many of them have pressures, which in the absence of an acute PE would be diagnostic of pulmonary hypertension. And so what we can see is that with catheter-directed thrombolysis, not only do the PA pressures come down, but we're actually able to measure them. We're not talking about getting a repeat echo in 48 hours and using an RVSP estimate. By having the catheter in place, we can get a direct pressure measurement prior to removing them and know if we've improved the patient's hemodynamics. So back to the case to highlight, this is an intermediate high risk patient. She is sick, she's tachycardic, she's borderline. She is someone who has significant RV dysfunction. She's a low bleeding risk patient. I think it's hard to justify the risk of systemic thrombolysis when we have so many other alternatives with even lower bleeding risks. But again, I think if we were at a hospital that didn't have access to transfer to a hospital that had the ability to do more interventions, I think there could be an argument made to do some degree of systemic thrombolysis. As I agree with Sophia that we should do something more than just anticoagulation. I think some of the benefits over catheter thrombectomy, in general, shorter time in lab and often able to use a smaller access catheter and potentially decrease our risk of growing complications. And unlike catheter thrombectomy, we have randomized data showing benefit. Hopefully, when we rehash this talk in a year or two, we will have randomized data for catheter-based thrombectomy. But right now, the fact is we don't have that data.
Well, Allison, thanks so much for summarizing that. That was really great. And I think before we get into our group discussion, we want to hear what you in the audience think. And so we'd really like to know, if you had all of these therapies available to you, what would you choose for this particular case? And so we're going to pull up this polling question here. Based on the information that was presented, what would you choose? Would you choose standard therapy with anticoagulation alone? Would you choose a catheter-directed thrombolytic approach? Would you choose mechanical thrombectomy or suction thrombectomy? Maybe you'd mix it up, something we didn't talk a lot about, systemic thrombolysis. Or maybe this is a patient who you would think about putting on mechanical circulatory support. So I'd love to see what you guys all would choose. Please go ahead and answer this question. We're going to leave it up here for just a minute here until we get a good representation of responses and then see what everyone thinks. So Evan, if we've got a good number here, maybe you can go ahead and close that poll and show us what people have selected. Awesome. So I'll review it in case folks can't see. We have about a quarter of people saying anticoagulation alone. I've got just under a third saying catheter-directed thrombolysis. I've got a little more than a third saying a mechanical or suction thrombectomy. And I actually have a couple people, 2 respondents who said, let's go for systemic thrombolysis. So I love the fact that we've got really some variation here. Before we, I'd like to stop there and maybe have a little bit of discussion amongst our panel and see what people are thinking. You know, we've talked a lot about the different approaches here, and there's a lot of pieces that really play into this. One question that has come up from this, and maybe Vlad, I'm going to turn this to you first, is what if this patient not only had been found to be a bit tachycardic, maybe a soft blood pressure with that enlarged RV, but what if we had actually seen some clot in transit there? I'm wondering, how does that influence the way you think about not just the risk stratification, but also just the technical ability to do some of these catheter-based procedures?
Yeah, that's a great question, Jeff. Thank you. I think that definitely comes up, thankfully not very often, but I think this is why every patient who's being considered for any type of catheter intervention, whether it's CDT or thrombectomy, we always try to get an echo on them first, because I've personally seen a couple of cases where that wasn't done and the procedure is performed and the patient actually decompensates. And in retrospect, you actually find that they probably have had clot in transit, and you still see some examples of clot in transit even after the intervention there. And you imagine that perhaps some of it may have embolized, or you were lucky enough and it did not embolize. So I think it's always important to make sure that that's not the situation. And I think that's the comfort level of the operator and kind of the institutional treatment algorithms kind of lead that decision. I think in some centers, FlowTriever technically has an indication for clot in transit. So I know some operators that would perform FlowTriever thrombectomy on clot in transit and then go up to the pulmonary arteries and perform the aspiration. I think in young patients who have a lot of clot in transit and also have intermediate high risk PE, personally, we always get our surgeons involved and at least get a surgical opinion. We have a very talented surgeon. And he has very good outcomes. So I feel comfortable with him performing surgery. And I think we always have that discussion with surgery versus procedures. And I think some patients in our institution, I think more patients go to surgery than for catheter-based interventions. For that reason, I think that performing catheter-directed thrombolysis, if somebody has clot in transit, is probably not the best option, because I'm worried that if I'm putting 2 catheters up, which is most likely the case for one for each lung, that I will flick that clot off, and then in the process don't know how the patient's hemodynamics will respond. So if I'm doing a catheter-based intervention, I think I would do FlowTriever, but I would certainly get a surgical opinion first.
You know, there's another question, and Allison, and maybe I'm going to turn to you first for this, is we talked a lot about catheter-based therapies here, and you made the argument for catheter-directed thrombolysis. Why not just go with systemic thrombolysis? You know, this is a young patient. She didn't have major bleeding risk factors. The PYTHO study would suggest if you're under, 55, 65, something like that, that bleeding is low. Why not just use the full dose of systemic thrombolysis in a patient like this? Does it depend on what you have access to, or do you think about lysis versus mechanical removal of clot differently? I'm curious how you might react to that question.
Yeah, I think it's a good question. I think that for me, the risk of intracranial hemorrhage, yes, it's low, but it's not zero. And I think intracranial hemorrhage is catastrophic. And the benefit seen is in decreasing the risk of decompensation. It's not, when they studied the PYTHO patients out for 2 years, there was no difference in long-term outcomes. And so what we're really talking about is improving our short-term outcomes. And to me, in an institution where there's other options, I think that risk is just one that I'm personally, I wouldn't be comfortable accepting for myself or my family member. And so I have a hard time recommending that for a patient. I think we're going to debate, but I think so much depends on your institution. And even within each institution, there may be variability in who's around and who's available. If it's a weekend and your on-call surgeon is scrubbed in a dissection, going after, a clot in transit percutaneously may be the right thing to do. I don't think that I think this is a disease state where we debate these things, but there's often more than one right answer for each patient.
Yeah, no, I think it's a great point. And of course, that's why we've chosen this one, because there's not a clear and obvious answer. Sophia, the next question I'd like to direct to you. Somebody said, well, what about safe dose systemic thrombolysis, or what's often referred to as half dose systemic thrombolysis? And there was some data out suggesting that maybe that's safe. We know that the PYTHO-3 trial is ongoing, really trying to test this. Is this a strategy that you employ in your system, and how do you think about that?
So great question, and the dilemma we all face. I think we don't know what the actual dose of TPA is or thrombolytic is for PE. We don't know. Do we need, if you look at Optelyze, do we need 2 milligrams? Do we need 4? Do we need 6? Do we need 8? Do we need 12? All the doses worked. So what is the actual dose? I think we don't have the answer until the PYTHO, the 3 trial helps us get that answer. However, using the MOPPET trial, however you weigh it, you can consider. If I do not have at my facility a safer option for this patient, I would consider, many audience have proposed this lower dose, 10 milligrams, 20 milligrams. What dose, I cannot tell you. I think, can you extrapolate the Optelyze, and see that even 10 milligrams may work for a patient like this? I would not give 100 milligrams of TPA to this patient. But yeah, can you consider, if you don't have any other option? Yes, you may. I think it'll be reasonable. Would I push an entire 100? No. So I cannot tell you because we don't know, but you can consider if you do not have a safer option to intervene.
Yeah, I think it's a great point. And so much of this is going to be based on what you have access to, not just in general in your institution, but at that moment, to the point Allison made earlier, right? If your surgeon is or is not available, and all those different things. That brings up another point. And Brandon, maybe I'll turn this one to you. What if you work at a hospital where you don't have access to folks who can do these catheter-based therapies, right? And so your option is you can anticoagulate them, you could give systemic thrombolytics at whatever dose you may think appropriate, or you can think about transferring that person. And I know you've worked in these environments before. How do you think through that? And how do you sort of make sure that patients are getting the best possible therapy when you may not have access to all of these right there at your institution?
Yeah, Jeff, I think that's a great question that most hospitals may or may not have access to interventionalists or the surgical expertise to perform surgical embolectomy. And I think it's really on a case-by-case basis. First, take inventory of what you actually have available within your institution and really counter that with the stability of a patient. So anytime that I think or question whether or not a patient should be transferred is really if they are stable to be transferred. And do we have appropriate protocol in place for receiving these patients and transferring those patients? I know there's a lot of good work within our colleagues through the PERT Consortium that has really talked on this with inter-hospital facility transport in these high-risk patients with pulmonary embolisms that really highlight these clinical scenarios that we often will face. But again, it's sometimes challenging if you're a receiving facility, relying on the expertise, the boots on the ground, as I would like to say, providing with clinically pertinent information about patients. And in some situations, if, going back to systemic thrombolysis or not, in those cases, it actually may be the only option that we have in a clinically decompensating patient. And, so that might be the only resource that we have. And as Allison had pointed out, if we are going to commit to those decision points, we need to really keep in mind the patient, their risk of bleeding, and whether or not we can effectively provide that treatment to them.
Yeah, I think it's a really great point. And obviously you need to be able to adapt to whatever is available at your institution, and having those protocols set up. And if you don't have all these therapies, having those relationships with other hospitals ahead of time is really key. Speaking about hospitals that have different therapies, Vlad, I wanted to turn this next one to you. You're somebody who does these various procedures. One of the things that sometimes comes up is, what other factors besides maybe the location of the clot influence whether or not it's safe to do a suction thrombectomy or a catheter-directed thrombolysis? And in this case, this was a patient who was fairly obese. And I'm curious, does sleep apnea, does obesity, do those factor into your decision-making for sort of the safety of doing the procedure and the ability to sedate or get them through the case? How do you think through some of those elements?
So I think in general, I try not to give sedation if I can to patients that we're treating with any type of catheter-directed thrombolysis. I think they're, especially the tachycardic patients with low index, they're maintaining their cardiac output by the virtue of the heart rate. And so, and their SVR is high. So, and I don't want to compromise any of those parameters and then suddenly drop their blood pressure. So I very rarely give any type of sedation, even minimal conscious sedation, unless the patient from the hemodynamics that I'm getting is more or less stable. But I think in terms of extremes of body weights, if somebody is morbidly obese, I'm actually slightly less concerned than if they're underweight. I think if they're obese, the main risk, I think, would be just the access site complication. But I think even so, you may be concerned that using a 24 French or 26 French access in the groin may be too much for a FlowTriever. But I think with hemostatic devices and with suture hemostasis, generally speaking, that's not been a concern. I think for what I've seen is in patients who are underweight, especially with catheter-directed thrombolysis, the heparin that they get during the procedure, especially if interventional cardiology is doing it and you're used to given a lot of heparin for PCI, for coronary intervention, the very thin patients, since they're getting TPA, even 2,000-3,000 of heparin during the case can run their ACTs and PTTs very high. And I think that's what can raise the risk of bleeding complications and intracranial hemorrhage and so on. So I'm actually more concerned about the underweight patients, but I think you do have to be just more careful from a vascular access standpoint for the morbidly obese.
Well, that's really helpful. Thanks for sharing that.
Sure.
The last question I'd like for us to address is, this is a case where we don't have a right answer. And as we've all sort of discussed, many of the ongoing or soon to be ongoing randomized trials are really going to, I think, help us have a better sense of what therapies are right for which patients. But one of the questions that's come up, and Allison, maybe I'll ask you to comment on this first, is what do you do when there are so many different options that are valid? And maybe we could treat with anticoagulation or catheter-directed thrombolysis or suction thrombectomy. When you're on the PERT call and there's more than one person there who has difference of opinion, how do you get to consensus so that you can actually treat the patient in front of you? What's been your experience?
Yeah, I think this is going to depend based on every PERT team and your setup. I mean, ultimately, it's up to the interventionalist on call, right? I can't tell Vlad that he has to do catheter-directed thrombolysis if he's the one who's putting in the catheters. We really do try to come to consensus. And I think when we're on the fence between whether or not to do an intervention or not, I think these are great patients to enroll in a clinical trial if you are at a site that has them. And I also think too, involving the patient in the decision, saying here, not getting into the specifics of this is what size French cannula we're going to put in, but we could watch you with anticoagulation. There's a chance that you may get sicker, but that would be one way would be to watch you very closely, see how you do, maybe put you in the ICU. The other option would be to do an intervention, but that is an invasive procedure. And there are some patients who are truly like, whatever you say, but a lot of people have opinions about their willingness to undergo procedures and their risk tolerance.
Yeah, I think that makes a lot of sense. And, in my experience, we've been running our PERT team now for about 7 years. We've never had true disagreement. There may be different options, but ultimately we can come to consensus and say, well, I think this is a reasonable approach to move forward. And so we've actually had pretty good experience there. Sophia, I'm just curious, have you run into any issues with your PERT program with difference of opinion, or do you generally reach consensus even if there are multiple good options?
So I think overall, generally, we do come to a consensus. And then, we are aware of our expertise. We are aware of what we can or cannot do in timely fashion. Like you guys have talked about, is the surgeon available if it's a high-risk PE? But maybe I'm on the bedside and he's on his way and I'm on call and he says, push TPA, I'm not there yet. If they're standing right there, like I always imagine, what if all of us are standing on the bedside? We have the surgeon, we have the intervention, all of us are there. What would we do first? Would we push TPA? Would we stabilize on ECMO and then intervene? So all those things are what I value over the years, and value more is what we're doing right now, that we are discussing and we are sharing our opinions to perhaps come up with the best option that we think is for the patient. And I'm okay with that, rather than making that decision myself, that we are going through that pros and cons, and it's 3 or 4 of us talking, or, that's very valuable to me, that we really have, because we don't know. And guidelines are just that, they're guidelines, and that's where they stop. So bedside medicine is very different. So the having this concept of PERT and this team discussion, the shared decision making, even you can involve the patient in that shared decision making, that this is all we know. We don't know if you're going to do this, that you're going to live more, or if we just do anticoagulation. But this is what we know. If I'm talking about suction thrombectomy, I can say that we do know with experience, or like you feel maybe better quicker, or with thrombolysis, data is good in reversing that RVLV, we can do that. So I think that shared decision-making is of value. That's what I've experienced over the years. And then you figure out, I would want that people who disagree to be on your team. I like that because, they give you that perspective. I always encourage to have that person who always disagree and invite them, because it makes you think. Because if all of you are agreeing on everything, then that's kind of like, okay, So I like that disagreement. Sometimes it makes you pause and troubleshoot, and in a healthy way. Not that, you know what I'm talking about, but I think it's good, healthy to say, no, I don't think so. No, sometimes people have come up with, I don't want to do it right now, but let's agree with when we will intervene. And we're like, okay, if these 2 liters is going into non-rebreather, or this tachycardia, which is 120, 130, if it goes to 140, 150, we are going in, and this is what we're going to do. So have that plan in place from the get-go. That has been my experience, even if we have paused for that watchful wait approach, which I wonder, what are we waiting for, sometimes. I'll stop there.
Well, I love that. And the ability to continue to watch and know when you're going to change course is a really great recommendation. Well, let's come back to the case. And Allison, you highlighted this really well. The PERT call in this case debated all these various treatment options and said, you know, there's equipoise. We don't know what the exact right thing is. This is a patient with an intermediate high-risk PE. We could use anticoagulation. We could do a catheter-based therapy. This happened to be at a hospital where the HI-PEITHO trial was able to enroll this patient. The patient met 2 of the 3 enrichment criteria with that sort of borderline blood pressure and the tachycardia. So they enrolled the patient and they happened to be randomized to the anticoagulation arm. And that's what we're trying to participate in. The patient was admitted to an ICU for 24 hours, then moved to a step-down unit for about 2 more days before being discharged home afterwards. And there was a follow-up echo done 2 days after presentation. There was still right ventricular enlargement with decreased right ventricular systolic function. The RVSP was at 40 at this point and pretty normal LV systolic function. So this patient will continue to follow according to the HI-PEITHO trial protocol. And hopefully we will see once that trial ends, what more we can learn about the different therapies here. And obviously other trials using the other different catheter-based approaches are going to give us additional information. So I really hope that 1 or 2 years from now, we're going to be in a much better data-informed space to be able to answer these questions. Well, I just want to say thank you. This was an incredible discussion. Sophia, Allison, Brandon, Vlad, you guys were an awesome panel, presented a bunch of great data and helped us think through this. I want to thank everyone on this call for participating. We had over 100 participants tonight. And I want to thank the PERT Consortium for hosting these webinars and for all of the sponsors who make this possible. Again, this and all the prior webinars are going to be at the PERT Consortium website. Thank you so much for being with us. And we look forward to seeing you on the next webinar and at the 9th PE Symposium in Austin this September.